Investigation of vasovagal instability and stroke, triggered by cognitive-autonomic overload on top of cerebral vascular damage, paper number 1494, VPT Sharp 055, January 6, 2026, Gerald C. EclaireMD Foundation. Category, Stroke, and Autonomic Dysfunction. Preface. My hemorrhagic stroke on June 21, 2025 was not an isolated event, nor was it the first major warning from my body. In early 2025, I experienced 2 near-collapse episodes while traveling to Texas for real estate investment activities. Each episode involved sudden dizziness, fainting sensation, and loss of postural stability, leading to emergency room visits. A third episode occurred on August 31, 2025, again characterized by near-syncope and autonomic instability, resulting in emergency admission at Stanford Hospital. At the time, these events were treated as separate acute incidents. Only after my stroke, and after carefully reviewing my longitudinal blood pressure, glucose, and behavioral data, did the underlying pathophysiological pattern become clear. These episodes were early manifestations of the same physiological mechanism that ultimately caused my stroke. They were warnings, not coincidences. This paper integrates my clinical events, 6 months of intensive post-stroke, physiological big data, family history, and later learned real-time autonomic control observations through the framework of Viscoplastopology, combining both solid and fluid dynamic plastic interpretations to explain causality rather than coincidence. Clinical observations and longitudinal data from attached biomarkers diagram attached at the end of this article. More than 6 months after my stroke on June 21, 2025, my average systolic blood pressure, SBP, remained between approximately 111 and 118 mm of mercury, which is considered well controlled for secondary stroke prevention. Pulse pressure, PP for vascular stiffness, ranged between 43 and 46 mm of mercury, slightly elevated, but stable and expected given my age of 79 and known vascular stiffness. After 36 years of type 2 diabetes history, fasting plasma glucose in early morning, FPF, values remained largely between 83 and 100 mg/dL, with average daily glucose, EcG, between 98 and 111 mg/dL, indicating stable metabolic control without alarming drift. Despite this favorable baseline profile, one variable consistently stood out as the dominant risk signal: systolic blood pressure, SBP spike amplitude. In the months immediately following my stroke, my SBP spike amplitudes frequently reached 15 mm of mercury, but by November 2025 onward, these values decreased toward from 12 to 13 mm of mercury. This physiological improvement correlated closely with behavioral and autonomic interventions, rather than medication changes. These observations confirm that my stroke risk was not driven by sustained hypertension or chronic hyperglycemia, but by transient, high-speed pressure excursions occurring on a structurally compromised vascular system. Actually, based on my averaged blood pressure records over the past 15 years, I was never classified as a chronic hypertension patient. My long-term averaged SBP values remained within ranges, below 120 mm of mercury, that would not typically trigger aggressive antihypertensive intervention. This further supports the conclusion that my recent stroke did not originate from sustained high blood pressure, but from transient, high-speed pressure spikes, acting on already stiffened and structurally damaged cerebral vessels by my shade T condition and aging. Vasovagal episodes as early system instability. All 3 pre-stroke emergency events share the same clinical signature: faintness, dizziness, near collapse, and autonomic instability without sustained hypotension or arrhythmia. This pattern is characteristic of vasovagal instability, which is not simply low blood pressure, but a rapid oscillation between sympathetic activation, fight, or flight response, and parasympathetic overcorrection. Sudden calming and blood pressure drop. In my case, the initiating factor was not physical exertion or dehydration, but cognitive and emotional triggers associated with high stakes interpersonal interactions, including deception, hidden agendas, game playing, moral frustration, and win or lose situations. These behaviors are common in adult social and business settings. However, in my health situation they triggered sudden sympathetic surges, fight or flight response, followed by excessive vagal compensation, sudden calming and blood pressure drop, leading to abrupt reductions in blood flow to the brain. These episodes did not cause immediate structural damage, but they revealed a loss of physiological tolerance or damping capacity, which is a critical early warning sign from a viscoplastopological, VPT, perspective. Cognitive speed, pattern recognition, and autonomic coupling. A critical clarification is required regarding the concept of cognitive overload. For me, overload does not arise from intellectual difficulty, smart work, or from long working hours. Combined with task volume, busy work. Throughout my life, Extremely complex thinking and high pressure working environments have been my normal operating state for decades, as reflected in my years of high-tech engineering leadership, long-standing pattern recognition abilities, and continued engagement in difficult and unconventional medical research. Even in my senior age, the overload in my case arises from speed and simultaneity, emphasizing that multiple thoughts, recognitions, implications, and emotional signals occur at once, not sequentially and not merely as parallel tasks. Particularly when rapid pattern recognition is coupled with emotional or moral conflict. When I recognize manipulation, deception, or strategic games within minutes, the cognitive recognition is instantaneous, while the emotional system activates at the same time, creating autonomic acceleration. Importantly, I often did not express anger outwardly, as I had learned to control my manner in adult social and professional settings. Instead, I contained it internally. This restraint helped maintain my image as a professional businessman. However, it also sustained elevated sympathetic tone without behavioral release. Physiologically, this is more dangerous than overt expression, because it keeps vascular stress high without resolution. In plain terms, it preserves outward psychological balance, but it quietly harms physical health. This distinction explains why intensive research work never triggered vasovagal events, while business negotiations and interpersonal conflicts did. My research provides coherence, flow, and resolution. But deception without closure creates sustained inner tension. Genetic predisposition and family history. My father died from a stroke associated with low blood pressure and low glucose levels, very similar to my recent stroke case except for the diabetes component. He was a high IQ medical doctor, trained in the German system before World War II, and was known for his short temper among family members and close friends. Retrospectively, his clinical course suggests a pontine or brainstem involvement, where autonomic control centers reside. This strongly suggests a genetic predisposition toward autonomic instability, rather than simple hypertension. Genetics did not determine the outcome, but they defined the boundary conditions. A fast brain paired with a fast autonomic, inner tension, response can be productive for decades, but when combined with metabolic damage, vascular stiffness, and aging, the margin of safety narrows. This inheritance pattern reinforces the need to look at my stroke risk beyond averaged blood pressure numbers and pay closer attention to dynamic changes, such as pulse pressure, PP, and SBP spike amplitude, solid and fluid dynamic plasticity perspectives. From the solid viscoplastic medicine perspective, my cerebral vessels had accumulated largely irreversible structural damage over decades of poorly controlled diabetes. Calcification and stiffening reduced elastic compliance, meaning the vessels could no longer absorb sudden pressure loads. This represents permanent deformation in solid mechanics terms. From the fluid viscoplastic perspective, blood pressure behaves as a flow system. The danger is not only blood pressure magnitude, but blood pressure rise rate, strain rate. Fast transients generate high local stress at vessel bifurcations, where blood vessels split or branch, and weaken microvascular segments, particularly in deep brain regions such as the pons. Stroke, therefore, occurred when a fast fluid dynamic spike acted on a brittle solid structure, exceeding the system's yield threshold. The earlier vasovagal episodes were not failures of blood pressure control, but early signs of instability in the body's flow regulation system, triggered by emotional stress. This combined solid fluid framework explains why average SBP appeared safe, while blood vessels rupture still occurred. Physiological damping through extended exhalation. One of the most important daily practical findings was the immediate effectiveness of slow nasal exhalation, lasting 6 to 8 seconds. This technique gradually activates vagal tone, the body's calming nerve response that slows the heart and lowers blood pressure, slows heart rate acceleration, reduces pressure, wave velocity, and dampens SBP spike amplitude, without lowering baseline or averaged SBP value excessively. Crucially, extended exhalation smooths transitions, rather than suppressing cognition or emotion. It decouples fast thinking from fast vascular response. This is not relaxation therapy, but mechanical damping of a fluid dynamic surge. The observed reduction in my SBP spike amplitude after November 2025 provides objective confirmation of its effectiveness. Why leaving Silicon Valley and real estate was protective. Stepping away from the Silicon Valley high-tech industry and the high-priced real estate sector, both filled with constant interpersonal mind games, was neither stupidity nor avoidance, but rather a protective adaptation. High-performance nervous systems are optimized for decisive action, not chronic provocation without resolution. In other words, I chose life itself over the socially defined targets of fame, power, and wealth. By removing persistent low-grade triggers, I reduced the constant inner tension in my body, allowing my body to respond better to simple control methods. This environmental modification was as important as any clinical intervention. Clinical implications. This case demonstrates that stroke prevention in high-functioning, Individuals with vascular stiffness requires monitoring dynamic variables, rather than static averages. SBP spike amplitude, autonomic transition, speed, and emotional cognitive coupling must be addressed directly. Extended exhalation for 6 to 8 seconds. Posture stabilization, early recognition of internal blood pressure surges, and environmental trigger reduction are not optional adjuncts. They are core components of secondary stroke prevention, when solid structural damage already exists and is largely irreversible. Conclusion: my stroke was not random. It was the endpoint of a long, visible trajectory marked by vasovagal instability, cognitive-autonomic coupling, genetic vulnerability, and structural vascular damage. Viscoplastopology, integrating solid deformation and fluid flow, dynamics and topological geometry changes, provides a coherent biomedical research framework to explain this progression. The most important lesson is that when structure is already compromised, fast speed of reactions and emotional responses become the enemy. Slowing physiological SBO spike transitions, not lowering blood pressure averages, is the key to survival. Epilogue: over time, I have come to understand why many patients do not read medical papers. Most are written for peer recognition, rather than for patients or normal readers. The language is often academic, dense, and abstract. While it may demonstrate competence to colleagues, it rarely helps ordinary people understand what is happening inside their bodies, or what they can do differently the next day. Patients do not avoid medical papers because they are lazy or unintelligent. They want to learn but they avoid them because the writing does not reflect their lived experience. Medical articles often focus on averages and labels, while patients live with physical sensations, uncertainty, worry, fear, and daily choices that affect their lives. As I worked through my own illness and recovery, I chose a different path. Because I was a trained scientist and engineer, not a medical doctor's, I tried to translate physiology into simple cause and effect that a normal person could recognize. I focused on explaining why something happened, not just naming it, and I replaced technical terms or jargons with plain words, writing with respect for the reader, rather than for reviewers or a small circle of medical specialists. That is why my writing gradually shifted from academic performance to fault conversational style. In a quiet way, I hope. This approach can be more helpful than many traditional publications. It helps people feel understood, recognize danger earlier, and gain practical tools they can actually use. Disclaimer: I write this paper not for fame, but to share what I have learned so others can understand their health, prevent disease, and live longer, healthier lives. This content is provided for educational reference only, and does not constitute medical advice. No doctor-patient relationship is created. You may share this summary freely, but it must not be altered, edited, or republished as your own. All intellectual property rights and copyrights for this article and its related materials belong to the author, Gerald C.